Hello, everyone. Thank you for the nice introduction, and thank you to organizers for inviting me to speak to you about liquid biopsies. So I lead two liquid biopsy studies in Wales. One is called Quick DNA, and the other one is called Quick DNA Max. The Quick DNA was about introducing liquid biopsy to lung cancer pathways. And I'm going to start with that to show you how liquid biopsy can help diagnose patients. And maybe that's something which can potentially be considered for cholangiocarcinomas. So just to give you a bit of context why we've introduced liquid biopsy to lung cancer diagnostic pathways in Wales. So the situation at that time when we started the study was in 2023. The lung cancer was the fourth most common cancer. It was a leading cause of cancer deaths. And as you can see, patients in Wales have been presenting with the late stage 3, stage 4 disease. And unfortunately, survival, as you can see on this chart, that orange line shows you that it drops down and to almost 15% 1-year survival for stage 4 disease. At the same time, in lung cancer, instead of chemotherapy and immunotherapy, we now have more than 10 targeted therapies. The genomic testing has developed significantly, and it's not just this basic treatments, but actually now more targeted treatments available. And they are very important because now we can offer these patients in the first-line treatment, so they need to be diagnosed quickly to get them to the right treatment. So on one side, you've got this great discovery, great treatments. On the other hand, you've got patients who are quite unwell, and they can't wait for the diagnosis or for the treatment. So we've got this 62-day NHS target pathway from cancer suspicion to treatment. It's about 62 days. We think it's quite too long for these patients to wait that long. And as you can see, more than 50% of patients in Wales were going beyond 62 days. And England as well, patients do go beyond 62 days. And not every patient can survive that long. And it's quite stressful for families as well. So what is liquid biopsies actually? So it's a blood test, and we can actually analyze different biomarkers in the blood. It could be DNA, RNA, exosome, cells, cancer cells, but we've been actually evaluating circulating tumor DNA. So what is circulating tumor DNA? It's a DNA fragments that are shared from cancer cells to the bloodstream, and we can offer patients then test the DNA from the plasma, and we can offer these patients the same genomic profiling as we use for tissue testing. So it's a bit non-invasive test and can give you almost similar profiling to the tissue genomic testing. So now I'm going to show you how we've introduced, where exactly in the diagnostic pathway we've used these liquid biopsies. This is a simplified version. Now we call this old lung cancer pathway, but it can actually be simplified version and represents all cancers, how they've been diagnosed and how they get to treatment. So starting from day 0, from potential GP referral or hospital admission, patient go through different investigations. CT scan is one of them, chest, abdomen and pelvis is being scanned, then patient see a specialist, and often tissue biopsy is requested, performed, and all these results, scans and histopathology is discussed at the multidisciplinary meeting where oncologists, radiologists, surgeons, pathologists all discuss every patient case, and they decide about the treatment. Often at this time, the genomic testing is requested, and that can take 2 weeks, 4 weeks, sometimes 6 weeks, and patients and clinicians waiting for the results until they can get the right treatment. So what we've done, we've introduced the blood test very early in the pathway. So as soon as patients have suspected stage 3 or 4 cancer on the scan, then the specialist could send the blood sample for this patient to Allwell's Genomics laboratory before even tissue biopsy was planned. And in that time, we've been analyzing, we applied 500 gene panel, and we provided the results for this important MDT meeting. So now this MDT will have radiology, pathology, and genomic results, and can then make a final decision on the patient treatment. If patient had a positive biomarker, then the patient can have appointment with oncologist sooner, and also can receive treatment sooner, because this therapy is often oral therapies, and they can start on the same day or the next day. They don't have to wait for chemotherapy slot or for immunotherapy slot. So that can reduce their time to wait for the treatment. So our aims were to reduce time from diagnosis to treatment, and also increase the rate of patients receiving these targeted therapies. Because we knew from previous audits that patients been diagnosed with the biomarker, but often didn't get the treatment because they become too unwell or pass away before actually getting the results. So this study now has close to recruitment last year in December 2025. We've recruited over 760 patients, and our failure rate for ctDNA was about 4%, and our waiting time to get results from the ctDNA from sample collection was about 13 days. We've managed to identify 15% of actionable mutations, but just bear in mind that this population is different to potentially the one you see in literature. This patient's been with suspected cancer. So we knew that there would be patients who had different cancer, or there would be patients with no cancer. If we would only calculate this for patients with lung cancer, it would be about 30%. So we're analyzing this data still, but we have some early results from first 113 patients. And what I can show you here, that we've detected more ctDNA, more mutations in the ctDNA, about 27 compared to tissue 22, which is expected because we know that tumors like all metastatic sites would share that DNA to the bloodstream, and all tumors are heterogeneous, and we can capture that heterogeneity with the ctDNA testing. But also this shows you that we detected some mutations we didn't detect in the ctDNA. So that means that it's probably more complementary rather than replacing the tissue testing. Also, this is the overview of all these over 100 patients. You can see patients with confirmed lung cancer, radiological lung cancer, patients with other cancers, or patients with no cancers. What I wanted to show you here is that the testing we performed was very highly concordant with the tissue results, with about 98%. And I want to draw your attention to this group of patients with radiological lung cancer. So these patients had multiple tissue biopsies or have no biopsies because they couldn't have them for technical or medical reasons. We also had patients who refused to have tissue biopsies. So these patients normally would not have any opportunity to have genomic testing. No tissue, no test. But with liquid biopsy, we were able to detect actionable mutations in 26% of patients. And one patient received treatment, and I will show you the story of this patient later. Just a brief overview how ctDNA compares with tissue when you're looking at timings. So we're looking from cancer suspicion to report. So the blue is the tissue, the ctDNA is the pink bar. So from cancer suspicion to report, we were able to, with the ctDNA, we were able to report about 3 weeks before tissue biopsy was available. And in terms of if you're looking from sample collection to the report, ctDNA we were able to detect, to give the results about 2 weeks before tissue. And a small number of patients, but the patients we were treated based on ctDNA results were able to receive treatment in less than 62 days. They were 45 days. 2 patients failed the ctDNA results, and they had to go through the normal tissue pathway. And as you can see, one of them was treated at 66 days, and the other one was 117 days. It's almost 4 months. So if patients can survive that long, they can be quite lucky, but if not everyone can wait that time. And we were quite fortunate because our patients, some of the patients were happy to share the stories on BBC Wales, and I will show you one of the stories of Philip Marks, who had 3 tissue biopsies. Unfortunately, none of them produced enough material to do genomic testing. So only thanks of ctDNA, he was able to receive targeted therapy. And also Pat Grant, who also received treatment while in hospital and improving by the time she got the results from tissue. And very important also patient who, with lung cancer, EGFR positive patient with lung cancer, Craig Maxwell, who never benefited from quick DNA, but he supported us. He's been fundraising and making sure all patients in Wales had access to this liquid biopsy test. So now I'm going to show you this short video, hopefully.
Now, lung cancer kills more people than any other form of cancer, with around 1,900 deaths a year in Wales. It is not the most common cancer, but part of the reason it has such a devastating effect is that it is often diagnosed at a late stage. Well, there are hopes that a new blood test that looks for tiny fragments of cancer DNA could lead to quicker diagnosis and better treatment. Our health correspondent, Owain Clark, has the story.
I'm very well, thank you. Yourself?
Checking in for his latest checkup. But last winter, Phil Marks from Coogan was so ill, he feared not reaching his 62nd birthday.
Wasn't eating, couldn't eat. And I actually said to my partner, take me to hospital. Otherwise, I'm not going to be here next week. And that's how bad I felt.
Phil already knew he had cancer, but doctors were struggling to find out its exact type. That's until the result of a new blood test came through, and Phil was put on new tablets.
From not being able to eat half a pasta meal, ping meal, I woke up on a Sunday morning and my partner said, well, what do you want to do? And I said, how about a carvery? She just burst into tears. Bless her.
The test Phil had is now available to anybody in Wales thought of having lung cancer which has grown or spread. But how does it work? Usually doctors try to find out more about someone's cancer by physically taking out tumour cells from the body, but these biopsies can be invasive and difficult. But as cancer cells grow and multiply, they release tiny bits of their DNA into the bloodstream. Patients give a simple blood sample, which is analysed by sophisticated machines that look for and read these fragments. Then, by knowing a cancer's genetic code, doctors can choose what treatment might work best.
So it's not only important to know whether there is actually cancer there and what stage it is, but it's actually important to know what biomarker this cancer have. And now patients, when they are treated, they have more than 10 treatment options in first-line settings. That means as soon as they're diagnosed, you have a cancer, you can start treatment with targeted therapy.
The rugby community has got behind us massively.
The rollout was made possible in no small part because of the efforts of this former rugby director, whose cancer developed before the test was available. Doctors became concerned about Craig Maxwell shortly before his 40th birthday. It took almost 3 months to find out he had inoperable lung and bone cancer.
We had to wait 78 days for my diagnosis. And when you've got limited time left, if somebody had said to me, here's 50 days back to spend with your family because you were in a better psychological state, I give anything for those 50 days back.
Craig then learnt new tests could speed things up for others. So by organising and taking part in several challenges, set about raising the extra £300,000 the team needed to deliver them. He's gone on to raise a staggering £1.5 million.
But what he's done has been absolutely incredible.
All I've done is run and cycle and climb mountains and talk about it. They've done the hard work. They're being part of that team. That means that if somebody like me walked into a hospital tomorrow knowing that there's a test that could benefit them, then I've been a small part of helping that. By far the proudest thing I've ever achieved.
Experts are now looking at how these tests might be used to detect other cancer types and eventually used as screening tests, which could revolutionise cancer care. But they also warn about wider challenges.
Patients are waiting too long. The demand is currently outstripping that capacity we have, and mostly that's workforce and machines, and we need more of those. But we also need to do more with what we do have.
But the new test certainly offers hope, not least for patients like Philip Marks.
I never thought I'd pick up a golf club again. I never thought I'd go on holiday with my family. And I've been able to do both.
He'll be forever grateful of the precious extra time he's had with family and friends.
So yes, Philip has had extra year with his family thanks of this test and thanks of this therapy that helped him to enjoy his time. And also we're very grateful to Craig. We've been joining all these challenges he's creating and trying to raise more money for more projects, which I will tell you now. The other thing is that last year in May, ctDNA was added to National Test Directory in exactly the same indication for suspected stage 3, stage 4 lung cancer. I don't know whether you know about this National Test Directory, but that means that patients in Wales and England can access this test as a standard of care. So this is now available to all patients in England and Wales. And our Welsh Oncology Thoracic Group has now updated the optimal national lung cancer pathway. And as you can see, ctDNA has been added to the top, the beginning of the pathway, and now all patients can access this test. And we didn't want to stop there. The last year, we've been trying to get to a new study called Quick DNA Max, and will be a platform study that will now start evaluating multiple tumor types, as we think now ctDNA can help other tumors as well. And we will be continuing with lung cancer, patients on treatment. We will be looking at a patient with prostate cancer, suspected colorectal cancer, and cancer of unknown primaries. And also we will be considering others as well. We feel that patients with cholangiocarcinoma and pancreatic cancer can also benefit from liquid biopsies, so we'll also be looking at this in the future, near future. And this time we won't only be focusing on diagnostic pathway, but we also will be looking at the treatment pathway. When patients already on treatment, the treatment stops working, and we now to retest the patient to try to find a new treatment or new clinical trial for the patient. So this is just a sort of what you already seen today for cholangiocarcinoma. The list of biomarkers is growing. It's quite comprehensive, and it starts to resemble the one for lung cancer. And there's been already some treatment approved in US. Not all of them been approved in UK, but they'll probably be approved very soon. And this treatment will potentially be offering to patients in first-line settings. Therefore, testing, like genomic testing, will be very important, and the timing of that testing will also be important. So I definitely see the value of this, and there's already some recommendations that if the patient fails the tissue testing, they can potentially have alternative of liquid biopsy to be tested, to at least have that opportunity to have that genomic testing, which could potentially change their treatment. And there are strengths and limitations of liquid biopsies and tissue biopsies. So in terms of liquid biopsies, the strengths that we can easily detect point mutations. It can be more difficult to detect fusions and copy numbers, but as the companies, the technology is improving, and they are working on improving this. And already today had some meetings with companies to show me that they can detect even fusions and copy numbers in liquid biopsy tests. And it's non-invasive test, and you can repeat at any time. You can repeat during treatment as well, and captures that heterogeneity of the tumor. Focusing is not only from the one point, from one place of the tumor, but it captures the whole sort of a molecular profiling of the whole tumor. And in terms of limitations, some tumors do not shed ctDNA or shed very minimal amount, and therefore then you might face with false negatives, but also you still have the tissue to be for you the testing. Okay, so that's really it from the liquid biopsies, and thank you to the big team working behind the scenes for all the projects. Thank you very much.